Great, thanks, Andy. Well, welcome everyone. I'm so glad that you could join us today. And as you can see from our title, that we're going to be talking about some of those other infections that just may not be quite as much on your radar. And I wanted to really point out this little quote down the bottom here: luck runs out, but safety is good for life. So I think that's a good motto for the day. Next slide, please. So today we're going to be talking a little bit about some of those other pathogens that you might see in your care settings. We're going to talk a little bit about how surveillance can help us detect and manage those infectious diseases, and then sort of some of the things that you may recall, the elements or the concepts from breaking the chain of infection. We can apply these to the disease processes we're going to be looking at today. Next slide, please. So before we get too far along, I just wanted to give a couple of updates that you may have seen in the news already. The first is that the FDA has authorized a second booster for those who are over 50 years old. It's been approved for both the Pfizer and the Moderna vaccines. And it's available to those who are over 50 at least 4 months after the last booster. And so this is in addition to, if you recall, there was they had made recommendations for those that were immunocompromised. Now they're extending that to the over 50 age group. The other thing I wanted to just share is that the CDC has released a new tool. It's a calculator that can help with figuring out the duration of COVID quarantine and isolation. And so Jean will be talking more about that on next week at the consult session. So there's a little teaser just to prepare you for that. Next slide, please. So let's talk about pathogens. So you may recall this slide from our last session. And really what this is highlighting is that pathogens can spread in a variety of different ways. And we're going to talk more about each of those during this session. Next slide, please. So we're going to start off talking about some airborne diseases. So these are diseases that have very small particles, and so they're tiny, and they can float on the air currents, and so they're able to travel large distances, which is why we have special air handling equipment when we're caring for someone in situations like in the hospital who have these contagious diseases. So TB, it's caused by a bacteria called Mycobacterium tuberculosis. And there's actually a number of different types of Mycobacterium that are often referred to as non-TB or Mycobacterium non-TB. So that's that tuberculosis piece that we are concerned about. As I mentioned, it's spread by airborne. So someone who has pulmonary TB or TB that's in the lungs, when they cough or sing or, basically just do anything that expels those tiny particles, anyone who's nearby who breathes those in can be infected. So it usually, we worry about the type of infectious TB that's in the lungs, but it can actually affect other parts of the body. So it can be found in the kidney, spine, and in the brain. In the community, what we worry about is the pulmonary TB, so when it's in the lungs. But in healthcare settings, if there's like someone's having surgery and they have TB in their spine, for example, there is potential for it to aerosolize, and so they take additional precautions. It is the leading cause of death worldwide. So even though we may not see large amounts of it in our community, other parts of the world do have a large burden. Next slide, please. So the way that we test and treat TB is pretty specific. So for testing or screening, we have two main methods. One is the PPG, which is that skin screening test where they put that little bubble of fluid under your skin and wait to see what happens. And the other is the quantiferon test, which is actually a blood test, and it's looking, or it's able to detect both active and latent disease. If somebody is exposed to TB and they have a positive skin test, There's usually additional diagnostics that will be done, like chest x-rays and things like that. But if it's felt that the person has latent disease, so they don't have an active infection, it's just sort of they've tested, their skin screening is positive, then they're usually treated with a single antibiotic, a Nasalid. And the idea behind this is to sort of prevent any disease from developing. For those who have active TB, we have good guidance from the CDC, and they actually recommend a longer term, so it's over several months, treatment, and it's usually multi-drug, and so they're listed here. These antibiotics are really hard on the body, and so it's very easy for people to be non-compliant with taking them just because it doesn't make them feel good. It can have side effects, which is why we give vitamin B6 to help prevent some neuropathy that can occur with being on these drugs. And so one of the main ways that TB therapy is managed is actually through direct observation therapy, or DOT. And this is when people are actually observed by usually someone in the health department actually taking their medications. Next slide, please. So another airborne disease that we worry about is that spreads by droplet is pertussis. And you may have heard this as whooping cough. Again, it's another illness that's caused by a bacteria, Bordetella pertussis. And so whooping cough or pertussis is sort of recognized by this very violent cough. And when people finally are able to catch their breath, they have this very unique whooping sound, which I'm not going to demonstrate for you. But it's a very sort of obvious sound, particularly in children and anyone who has sort of, is having severe coughing fits. It can affect people of all ages, but it can cause very serious infection. In a typical, healthy adult, it's going to just usually be a persistent cough that just lasts for several weeks. But it can be deadly in the very young. So those who are less than 1 year old who are not yet eligible to be vaccinated, and in the older adults. So when we think about how we can prevent transmission, the best way that we have is vaccination. So we have two types of vaccines available to us. We have the Tdap, which is for adults and older children and teens, and it contains tetanus, diphtheria, and pertussis. And there's been a lot of work around, ensuring that adults, particularly if they're in the childbearing age, or they're going to be around very young children, to get vaccinated to help protect those susceptible infants. And then we have a vaccine for those who are 2 months through 6 years, and they can get the DTaP, which is diphtheria, tetanus, and pertussis. So next slide, please. So this is an airborne disease, but it's also transmissible by contact. So the fluid and the little skin scabs that form from this rash can be spread via contact. So when we have people with chickenpox or varicella, we use both contact and airborne isolation. So it's very contagious. And it's caused by the varicella zoster virus. So unlike the others that were bacteria, this is actually a virus. It causes this rash. And at first usually appears sort of on the chest, the back, and maybe the face. And then it starts to spread over the entire body. Very, very itchy. And it can be potentially serious and even deadly. And I think we've kind of forgotten how serious these illnesses can be because we've had vaccinations available to us and we don't see it in the same way that it was pre-vaccine. So again, the main way that we can prevent transmission and control infections is through vaccination. And so usually children are vaccinated. And then there's sort of a key caveat with around this particular virus infection is that pregnant employees should not take care of anyone who has varicella or shingles if they've not had the disease or the vaccine, because it can impact and have detrimental effects on their newborn, or during the pregnancy. So it's also important to remember that people can lose their immunity to measles, mumps, and the chickenpox. And so oftentimes, if you're going into healthcare, you may have had to have titers so that you know that you have immunity. Next slide, please. So this is just highlighting shingles, which may be a little bit more familiar than chickenpox in your settings. So it's the herpes zoster, requires contact precautions, again, because those little vesicles and the skin scabs can be a means of transmitting. It's a reactivation of the varicella virus. So if you've had shingles, chickenpox, the virus can lay dormant in the dorsal nerves and erupt or become active, and usually in times of high stress, low immunity, it can take hold. It typically will form a rash on what we call a single dermatome, so it may be just sort of like one side of the abdomen, one sort of patch of the arm or leg across the buttock, and so we just, usually manage that, as I said, with contact precautions. If the rash is much more dispersed, we call that disseminated shingles, and that requires airborne precautions, because we think that when the disease is that severe, where it's maybe covering both sides of the body, both arms, both legs, there's just so much rash, that they may be able to, there may be some spread from the airborne route. There are work restrictions around having this, and so it's important to make sure that if healthcare workers do let you have shingles, that they follow those work restrictions. And there is a vaccination available for those who are over 50. Next slide, please. So we're going to switch a little bit from the airborne methods of transmission and talk a little bit about foodborne, which is when we think about a vehicle. And so one of these is salmonella. There's lots of different types of salmonella out there. And some you may have heard of as typhoid fever. It's usually caused by eating contaminated food or contaminated water. But you can also acquire it through the touching of infected animals, their feces, or their environments. And so some pets, particularly sort of the reptilian type, so the bearded dragons or lizards, turtles have also been associated with outbreaks of salmonella. And I think the CDC currently has on their website an outbreak that's associated with the bearded lizards. So just to be something to be aware of, that good hand hygiene is very important when handling those types of animals. When we think about food, oftentimes it occurs in the summer, and it's associated with outdoor eating, like picnics. Think about egg sandwiches, anything that has maybe been contaminated during the preparation and is not stored at the correct temperatures and has an opportunity to grow. So typically people who have salmonella, they'll start off having some diarrhea, fever, and stomach cramps. They can start anywhere from 6 hours to 6 days after the infection. So sometimes it's very hard to kind of associate what may be the cause with the symptoms. And again, some people may not develop symptoms for even longer. And the symptoms can last for long periods of time. So again, it's really important to make sure that anyone who does have any kind of symptoms that are related to foodborne illness, like diarrhea, vomiting, stomach cramps, that they are not preparing food in the kitchen. Next slide, please. Another illness that comes up every now and then, it's rare, but it can cause really severe illness, and that's botulism. And it's caused by a toxin that can actually attack the body's nerves. And so we'll talk a little bit more about the source in a moment, but when we think about the symptoms of botulism, they usually begin with some muscle weakness. It's often around the eyes, face, mouth, and throat. And then the weakness can spread. And so it can spread to the level where the muscles, our chest muscles, the muscles we require to actually breathe, can be affected. And so people can end up with almost like a paralysis if they don't receive medical treatment. Next slide, please. So that last slide had, some preserved jars. And so when we think about where we can find botulism, we have to also think about the types of botulism that are out there. So there's a number of different kinds. So we're going to just run through these really quickly. So we have wound botulism. This is when the spore of the bacteria are able to get into a wound and they create the toxin. They have a nice environment in which to grow. And so it can happen often after a traumatic injury where dirt, soil may have had an opportunity to get into a wound and take hold. There's foodborne botulism, which is associated with preserved, canned, or fermented foods. So when you have a can or you open a container and it doesn't maybe have the correct little pop when you release the lid, or there's a concern for contamination, one of the things we worry about is the potential for botulism. There's also iogenic botulism. This is actually associated with receiving Botox injections. And so if you get too many of those, it can actually cause infection. And so people are using Botox obviously for, we sort of think about it for cosmetic reasons, for wrinkles and for filler, but people are also using it as part of a migraine therapy. So it's possible with multiple injections that you could develop a type of botulism. And then there's what we call adult, and it also happens in infants, intestinal botulism. And so this is when those spores get into our gut. They find that they have the perfect environment in which to grow. They can produce the toxin. And then, it causes havoc within the gut, can cause all kinds of issues. So just something to be aware of when it comes to things that are foodborne. Next slide, please. So we're going to take a look at methicillin Staphylococcus aureus, or MRSA. So we have two main types of MRSA that we are concerned about. We have a hospital strain, which we often call healthcare associated MRSA, and we have a community strain, community associated MRSA. Oftentimes when people, particularly in the community, they have MRSA, it may present as a spider bite, it may be a large pimple, it may be a boil, or almost like an impetigo type presentation. And so antibiotics is the treatment. The problem is that if it's resistant to our most commonly used antibiotic, which is penicillin, it may not work. And so we need to be using a bigger gun in the antibiotic world. So when it comes to the community-acquired MRSA, it can actually be more virulent or cause more severe disease than the hospital-acquired type. And typically it is found for those who are living in crowded or unsanitary conditions. People who participate in sports may get like abrasions from like artificial turf or from mats that are contaminated and haven't been cleaned properly. It's also associated with intravenous drug users. So some of the injection areas can become infected. HIV and those men who have sex with men are also can be a high-risk group. Next slide, please. So another disease that we can encounter in our care settings is Legionella. It's a bacteria that's typically found in water environments. So it's found naturally in streams and lakes. It becomes problematic when it ends up in our healthcare systems or in our buildings because we have sort of very complex water systems. And so some of the places where we can find that it's able to be problematic is shower heads, cooling systems in buildings, hot tubs, water tanks and heaters. Decorated fountains and water features are also another place where Legionella can thrive. So it spreads by droplet, usually small enough for people to breathe in. So someone who's, turns on the shower, maybe that's been in an area where there's, water's been sitting for a while, disruption in the pipes can have the Legionella break off the bioburden and come out in the water. Or it could just be walking around or spending time in an area where there's a contaminated water fountain. So it's possible to aspirate from contaminated drinking water. And typically symptoms, like many symptoms, are very sort of vague: a fever, cough, chills, or muscle aches, which is why it can be difficult, and there can be delays in treatment and recognition, just because symptoms are pretty generic. So those who are most susceptible are those who are over 50, those who are immunocompromised, anyone who has any kind of respiratory chronic disease or immune, like cancer, diabetes, and those who smoke. Treatment does require antibiotics. And it does, severe disease, 1 in 10 do die from Legionella. So it's a reportable condition. Next slide, please. I want to touch on bloodborne pathogens really quickly. So we have 3 main pathogens that we are concerned about from an occupational health and safety perspective. The one that really has the greatest risk of exposure, or the risk of infection after having had an exposure, is actually hepatitis B. But fortunately, we actually do have a vaccination for that. Which is very effective. It's that 3 series that you receive. And if you have an exposure with hepatitis B, treatment should be started within 24 hours if people do not have immunity. And then hepatitis C, again, is one of the things we worry about with exposures. It can remain in viable blood for up to a week. So that really highlights how important it is that we clean and disinfect our equipment, where we may be like glucometers and things like that. And fortunately, there's no vaccine, but we do have better treatment therapies. And then HIV, again, is associated with a relatively low risk compared to the others. But there are a number of variables, such as sort of the size of the needle, what the viral load is of the person who's the source, that can all have an impact. Next slide, please. So there's a number of different strategies for prevention. The CDC has the 1 needle, 1 syringe, 1 time campaign. And so really it's just highlighting the importance that we should never be using any kind of finger stick device on more than 1 person. Ideally, glucose meters should not be shared. They should be assigned to an individual. And then just being very cognizant about what happens with insulin pens and other types of medication cartridges. And anytime we're using or entering any kind of vial, we want to be using a new syringe and needle. Next slide, please. So of course, we have our other friendly pathogens that are out there that we've talked about in the past. So this is just highlighting some of those that we've talked about before, that we need to make sure that we keep on our radar. Next slide, please. So we wanted to spend a little bit of time talking about some of those common infections that can lead to hospitalization, and also have are of concern because we can often overtreat with antibiotics. And so many of the diseases that or pathogens we've talked about have resistance patterns that are of concern. And so when we think about different types of infections that can end up leading people to be in the hospital, we need to be paying good attention to it. And so while we have UTI and pneumonia and cellulitis, we're really going to focus on UTIs today. Next slide, please. So this is the definition of a urinary tract infection. And I really want to point out that this is what we call a surveillance definition. So this is something that we would get from NHSN, that the infection preventionist is going to look at and compare, research any infection that may have been diagnosed by a clinician and see whether it meets this definition or not. And so there can be a difference between what we say is a surveillance definition and would call an infection or not, and what someone is being treated for. And so the way that we use these surveillance definitions is that they're population-based. So we're looking at lots of different infections and sort of the numbers of the frequency of things. And then we look at this type of data from surveillance to help us find and define best practices around how we can prevent them from happening, as opposed to, you know, a clinician who's seeing their single patient on an individual basis. Next slide, please. So when it comes to testing of urine to diagnose a UTI, there's a number of different strategies, and a pretty common one is to just do a dipstick, you know, just to do a UA to see if there's any leukocytes. And so a lot of times, if leukocytes are seen, it's assumed that the person has an infection, and that's not the case. And so we need to have other elements present for us to determine that the person really does have an infection. And so one of these is actually the culture. So it's important that if a UTI is suspected, that a sample is sent to the lab for culture, so we know what's actually growing, if anything, and we know what we need to treat it with. So we need the sensitivity to tell us what antibiotics are going to be the most effective. Typically, from a surveillance perspective and best practice, if the culture comes back with less than 100,000 colony count of one organism, it's not considered to be an infection. And if it has more than 2 different bacteria, so say it does come back as over 100,000, but there's like multiple bacteria, then again, we would not consider that to be an infection. We'd really be more looking at that as being a contaminant. Next slide, please. So there's a number of different reasons why urinary tract infections happen. And so we know that age is not a determinant. They can happen at any time. And they're typically from a bacteria. E. coli is probably the most common one that we see. And partly the most frequent ones we see are those that are also found in the gut. And if you think about sort of the proximity of our, you know, gut to our urethra, that's not very far. And so it's easy for bacteria to travel. Anyone who has a catheter or lives in a nursing home or other full-time care facility, other bacteria like enterococci and staphylococci are also common causes. So again, E. coli may not be the primary one that you see. You may have others that are enteric more to your environment. There's a few things that do put older adults at risk for developing a UTI. This includes having a previous history. So if someone has recurrent UTIs, they may be more prone to them in general. Dementia is another reason. Catheter use. So obviously having an invasive device gives people greater risk. Bowel and bladder incontinence, and then a prolapsed bladder can also contribute to infection. Next slide, please. So this is a nice little illustration of some of the ways that we can prevent UTIs from happening. And one of the first things is to make sure that we keep residents and ourselves hydrated. So making sure that we drink plenty during the day helps just to flush the system out, helps to keep any bacteria sort of just passing through and not giving it the opportunity to sort of be stagnant in our bladders. Another is to remove Foley catheters unless they're absolutely necessary. So thinking about some of the alternative mechanisms that might be available if somebody has had the need, or reassessing, you know, having those discussions. Perineal hygiene is another really important way that we can help prevent UTIs. Many people who are older, who maybe don't have good mobility, they may not be able to provide their own hygiene adequately, so they may need some additional assistance or some other, you know, special wipes or something else that can help facilitate perineal hygiene. Changing a brief after bowel movements or incontinence is really important. It kind of goes along with good perineal hygiene. But again, if people are sitting in soiled breathes, then there's much greater risk of bacteria that's in the gut, in the stool, being able to travel to the bladder. And then again, making sure that we're doing regular toileting, making sure that we don't have urine stagnant in the bladder. Next slide, please. So along with some of the ways that we've talked about preventing infections and controlling them, cannot emphasize enough the importance of environmental disinfection. So typically, and certainly previous to COVID, cleaning and disinfection of surfaces may have only happened once a day, but we've really learned that we touch things a lot, and we can really lower the burden of pathogens in our environment if we do more frequent cleaning and disinfection. And so recognizing how often things are done, who's responsible for doing it, and thinking about those high touch areas and where there's opportunities for reducing that burden. And so I'd ask if I see people, Andy put in the chat, just to make a note in the chat of what you think are some of the high touch areas that you have in your work environments. Next slide, please. And so there's a few high risk times, or times where we really need to pay a little bit of extra attention to those in that environmental disinfection. And so one is before thinking about where we place food or drink, particularly if we're using an overhead or a bedside table. Think about all the things that perhaps go onto those bedside tables. I've seen all kinds of things: urinals, other food, books, magazines, who knows what gets put on those tables, because they're easy to reach, which is the purpose. Before and after any aseptic or clean procedure. So you want to clean or wipe the surface of the table or the cart that you might be using if you're doing a dressing for a wound, or you're going to be doing a catheter insertion or change, anything like that. You want to clean the environment after any procedure or task where there's been, involving any kind of bowel bladder care, and also for respiratory secretion. So if somebody's been suctioned or had a nebulizer or anything like that, you want to make sure that those areas have been cleaned, because there's been, things have been aerosolizing, and there's potential for environmental contamination. Again, thinking about bathing. So, bathing somebody, changing their linens, particularly if they're having a sponge bath or have a shared environment, we want to be cleaning more frequently those areas. And then, of course, anything that ends up on the floor that we need to be paying attention to, we either need to replace, or it needs to be very carefully cleaned and disinfected. And the same with any kind of shared equipment that we might be using. Same thing applies. Next slide, please. And with that, I'm going to turn it back to Andy and open it to any questions.
So Carrie, we do have one question in chat. Todd asked us, is cranberry juice really effective in preventing UTIs? We've got a lot of clients using it or taking cranberry pills.
That's a great question. And, I know that that's out there, and I confess that I have not got a strong knowledge on that, but I'm going to hand that to Jean.
I do. All the research has shown that it really doesn't work. So if they're spending a lot of money on the cranberry tablets, they're really wasting their money. But what it does do, if you're giving them juice, at least it's hydration. So that's a good thing. But the cranberry part of it, once upon a time, we used to think that it was acidic and that would change the pH in the urine. And that just has not proven through the evidence to be true. So just so you know, people take it because it makes them feel better, but there's no research to support it. I just read about that recently because I was doing another UTI presentation for another Comagin group.
Thanks, Jean. And we did have a couple of people share in chat some of the high touch areas: doorknobs, doors, telephones, computers, wheelchairs, counters, furniture, shared bathrooms at the office.
Yeah, great. And particularly if there's any kind of GI outbreak happening in your environments, any kind of shared public bathrooms, they are definitely an area that you want to be increasing the cleaning of. So great, thanks for sharing those.
And that's all I see in chat. So we'll go ahead and move on to be mindful of everybody's time.